Hello friends, today let's discuss the topic classification, therapeutic effects and uses of the following: active exercises, free, assisted and resisted exercises, and passive exercises, relaxed and forced exercises. So let's start with the introduction. Therapeutic exercises are bodily movement prescribed to correct impairment, improve musculoskeletal function, or maintain a state of well-being. It may vary from highly selected activities restricted to specific muscles or part of the body, to general and vigorous activities that can return a convalescing patient to the peak of physical condition. Therapeutic exercises are classified into two types of exercise, namely active exercise and passive exercises. In active exercise, we have free exercises, assisted exercises, and resisted exercises. In passive exercises, we have relaxed exercises and forced exercises. First, let's start with the active exercises. In this, we have free exercises. Free exercises are those which are performed by the patient on muscular effort without the assistance or resistance of any external force other than that of gravity. This type of exercise can be used to obtain any of the effects which are produced by exercise as a whole. The great advantage of free exercise lies in the fact that once the patient has mastered the technique of the performance and is aware of the purpose, it depends on oneself to practice when and where he wants. Here comes the classification of free exercises. Free exercises may be classified according to the extent of the area involved. They may be localized and general. First, start with the localized. Localized exercises are designed primarily to produce some local and specific effect. For example, to mobilize a particular joint or to strengthen particular muscle groups. Movement is localized to one or more joints either by the use of suitable starting position or by voluntary fixation of other area by the patient on muscular effort. General exercises. It usually involves the usage of many joints and muscles all over the body and effects is widespread. For example, as in running. So here comes the character of free exercises. First one is subjective and second one is objective. So here comes the subjective one. Exercises which is subjective is usually formal and consists of more or less anatomical movement performed in full range. The attention of the patient is deliberately focused on the form and the pattern of the exercise. And the second one is objective one. Objective exercises are those during the performance of which the patient's attention is concentrated on the achievement of a particular aim which will result from his effort. So the next topic comes the technique of free exercises. So the first one is the starting position. The starting position is selected and taught with care to ensure the maximum postural efficiency as a basis of movement. And second one is instruction. Instruction is given in a manner which will gain the interest and cooperation of the patient and lead him to understand both the pattern and purpose of exercise. And third one is the speed. The speed at which the exercise is done depends on the effects required. It is usually slow during the period of learning and later the patient is either allowed to find his own natural rhythm or the speed required is dictated by the physiotherapist. Fourth one is the duration. The duration of the exercise depends very largely on the patient's capacity. So here comes the next topic, the effects and uses of free exercises. First one is relaxation. Rhythmical swinging movement and those which are pendular in character assist the relaxation of hypertonic muscles in the region of the joint moved. Second one is joint mobility. The normal range of joint movement is maintained by exercise performed in full range. The third one is muscle power and tone. The power and endurance of the working muscles are maintained or increased in response to the tension created in them. The tension is greater when the exercise is performed at any speed which is slower or more rapid than when the natural speed of movement is employed. And fourth one is neuromuscular coordination. Coordination is improved by repetition of an exercise. As the pattern of movement is established, it is simplified and become more efficient, and the conduction of the necessary impulse along the neuromuscular pathway is facilitated. And the fifth one is confidence. The achievement of coordinated and efficient movement assures the patient of his ability to maintain subjective control of his body. The sixth one is circulatory and respiratory cooperation. During vigorous or prolonged exercises, it is apparent that the speed and depth of respiration is increased, that the heartbeat is faster and more powerful. And here comes the next topic, assisted exercises. When the force is exerted on one of the body lever by muscular action is insufficient for the production or control of movement, an external force may be added to augment it. The magnitude of the assisting force must be sufficient to augment the muscular action and must not be allowed to act as a substitute for the movement. So here comes the technique. The general plan is to ensure that the insufficient muscle exert their maximum effort to produce movement under conditions designed to facilitate their action. The assisting force is applied neither only to augment this maximum effort nor to act as a substitute for the movement. So here comes the next topic, that is effects and uses of assisted exercises. First one, the working muscles cooperate in the production of movement which they are incapable of achieving unaided, provided the maximum effort of which they are capable is demanded from the weak muscles and assisting force utilized is only complementary. These muscles will gain in strength and hypertrophy. This type of exercise may be used in early stages of neuromuscular re-education. And second one is the memory of the pattern of the coordinated muscles is stimulated by the correct performance of a movement which the patient is unable to achieve without assistance. So, assisted exercise may therefore be helpful in training coordination. And third one, confidence. Confidence is the ability to move is established when the patient observes the movement and the fact that each muscle cooperates in producing the movements. When movement must be maintained in spite of pain in joint, this exercise is very useful. For example, in RA, that is rheumatoid arthritis. And the fourth one, the range of effective joints movement may be increased by assisted exercise. However, as both range and control are often dependent on the efficiency of the muscle working over the joint. So here comes the next topic, resisted exercise. Principle of resistance. An external force may be applied to the body lever to oppose the force of muscular contraction. The tension is created within the muscle by the opposing force, and the muscle responds by an increase in the power and hypertrophy. There are factors which contribute to the development of muscular efficiency. That is, 1. Power, 2nd. Endurance, and 3rd one is volume. So first come with the power. Power develops in response to the application of the maximum resistance, which is consistent with the ability of the muscle to overcome it. As the essential factor in power development is the magnitude of the resistance, the method used to promote is called progressive resistance exercise. And second one is endurance. Endurance is a quality which develops in response to repetitive contraction. Therefore, it is a number of contraction which is the essential factor. The method used in this case is called low resistance, high repetition exercise. And third one is volume, which can be observed or measured as an indication of hypertrophy, usually develops in the proportion to power. It serves as a means of demonstrating progress to the patient, although it is not invariably a reliable indication of successful treatment. So here comes the next topic, effect and uses of resisted exercises. First one, muscle power can only be maintained or increased by contraction, and in these exercises, the working muscles are strengthened and hypertrophied in response to tension created in them by the resistance. Their power and endurance is increased. Resisted exercises are used to build up weak muscles and so to restore the balance of muscle power, which is essential for stability and coordinated movements. Second one, the blood flow to the working muscles is increased in proportion to the amount of work they are called upon to do, thus providing the material for repair and hypertrophy. Although the blood flow is impeded during the actual contraction, the amount of blood contained in the muscles immediately after contraction may be as much as 10 times as greater during strenuous exercise as the amount contained during rest. The increase in blood flow to the muscle continue for some time after exercise, bringing oxygen and nutrition to the part and assisting the removal of metabolic products. Third one, a general rise in blood pressure frequently anticipates exercise and may be increased by the mental effort required to perform this exercise correctly. And fourth one is heat, which is produced as the result of strenuous muscular activity, stimulates the heat regulating center, causing vasodilatation in the skin. This follows as constriction of these vessels, which occur in the first place to compensate for the increase in the blood flow to the muscles. So here comes the next topic, that is passive movement. These movements are produced by an external force during muscular inactivity or when muscular activity is voluntarily reduced as much as possible to permit movements. So here comes the principle of relaxed passive exercises. First one is relaxation. A brief explanation of what is to happen is given to the patient, who is then taught to relax voluntarily, except in case of flaccid paralysis, when this is unnecessary. The selection of a suitable starting position ensures comfort and support, and the bearing of the physiotherapist will do much to inspire confidence and cooperation in maintaining relaxation through the movement. And the second one is fixation. When movement is to be limited to a specific joint, the bone which lies proximal to it is fixed by the physiotherapist as close to the joint line as possible to ensure that the movement is localized to that joint. Otherwise, any decrease in the normal range is readily masked by compensatory movement occurring at other joints in the vicinity. And the third point is support. Full and comfortable support is given to the part to be moved so that the patient has confidence and will remain relaxed. The physiotherapist grasps the part firmly but comfortably in her hand, or it may be supported by axial suspension in slings. The latter method is particularly useful for the trunk of heavy limbs as it frees the physiotherapist's hand to assist fixation and to perform the movement. The physiotherapist's stance must be firm and comfortable. When standing, her feet are apart and placed in the line of the movement. And the fourth one is traction. Many joints allow the articular surface to be drawn apart by traction, which is always given in the long axis of a joint, the fixation of the bone proximal to the joint providing an opposing force to a sustained pull on the distal bone. Traction is thought to facilitate the movement by reducing intra-articular friction. And the fifth point is range. The range of movement is as full as the condition of the joint permits without producing pain or spasm in the surrounding muscles. In normal joints, slight overpressure can be given to ensure full range, but in flail joints, care is needed to avoid taking the movements beyond the normal anatomical limits. And the sixth one is speed and duration. As it is essential that relaxation be maintained throughout the movement, the speed must be uniform, fairly slow and rhythmical. The number of times the movement is performed depends on the purpose for which it is used. And the next heading is effects and uses of relaxed passive movement. First point, adhesion formation is prevented and the present free range of movement is maintained. One passive movement, well given and at frequent interval, is sufficient for this purpose, but the usual practice is to put the joint through two movements twice daily. Second one, when active movement is impossible because of muscular inefficiency, these movements may help to preserve the memory of movement pattern by stimulating the receptors of kinesthetic sense. Third one is when full range active movement is impossible, the extensibility of muscle is maintained and adaptive shortening is prevented. The fourth one is the venous and lymphatic return may be assisted slightly by mechanical pressure and by stretching of the thin wall vessels which pass across the joint moved. Hence, quick, rhythmical and continued passive movement are required to produce these effects. They are used in conjunction with elevation of the part to relieve edema when the patient is unable or unwilling to perform sufficient active exercise. And the fifth one is the rhythm of continued passive movement can have a soothing effect and inducing further relaxation and sleep. They may be tried in training relaxation, and if successful, the movement is made imperceptibly and progressively slower as the patient relaxes. So here comes the conclusion of today's topic. Therapeutic exercise is a key component of any rehabilitation program. Physical therapists have been utilizing therapeutic exercises with great success. So from the above discussion, we can well understand that there are several exercises which are of great value in treating a patient with several dysfunctions.